a physician that can say, it feels like prescribing beauty in your life.
Yeah,
And
absolutely.
part of it is like, okay, we're also working with burnout of staff, of, healthcare, of so many different people. We're all pretty tired after 3 long years of the pandemic. And, just really looking at, when there's still so many challenges, especially in mental health and providing access to mental health care, some of these pediatricians were saying, like, gosh, at least I could do something. At least I could prescribe something that could feel like it can make a difference. And that's where you have a quote like, "This was the best doctor's visit I've had in 72 years. It was so fun because I get to have theater tickets." And what that feels like, especially as we emerge after so much isolation.
In this roundtable discussion, Diantha Del Scholl is joined by arts and health professionals Tasha Golden, Director of Research at the International Arts and Mind Lab at Johns Hopkins Medicine, Sudha Sriniwas, Professor in the Department of Human Development and Family Studies at University of North Carolina, Greensboro, and Käthe Swaback, Creative Youth Development Program Officer at Mass Cultural Council, to discuss the topic of social prescribing in the arts and how this practice is perceived, explored, and researched in the US, and in some cases implemented in other countries to support older adult health and wellness. Each guest addresses the challenges and explores the opportunities that this practice has on improving healthcare, the arts and aging field, and older adult physical and mental health through arts participation.
For those who are new to the topic, I thought I'd start by offering a simple explanation of social prescription for the arts, and any of you can correct me afterwards or add to it. It is a framework, I think I use that word, that involves healthcare professionals writing prescriptions for community activities or cultural experiences that address what we call the social determinants of health. And those are non clinical issues such as loneliness, lack of purpose, discrimination, or other problems arising from the conditions in which people are living. Now, while experiences in nature are volunteering, are often those that are prescribed, cultural experiences are another avenue. Through your collective research into and your knowledge of social prescribing for the arts in other countries, what are you learning about how these programs influence people's access to arts participation and, possibly if known, access to participation for older adults in particular?
The countries that we have interviewed have universal health insurance. So social prescribing in these countries has improved everyone's access to the arts. It has brought it on the radar of people who may not have had it on their radar before. That is, I'm talking of patients and also of providers and prescribers. And for many of the older people who have participated, they have described it as a life-changing and positive experience. They have made new social connections and they have improved aspects of mental well-being. Now, the thing with participation is that it's linked to awareness and access. The link workers or connectors make people aware of what's out there. So the tree is you begin with somebody identifying that a patient has a need and then making a referral. And the link worker or connector picks up the referral and then with their knowledge of the programs that are available, connects the participant or the patient to those programs. And now the prescribing arts and prescription has not necessarily increased arts participation for just everyone, because many people who somehow are excluded from the health system or not connected to at least a primary care physician are harder to access and they are not connected to link workers or social prescribing.
Yeah, I mean, I just feel like there's been some incredible research done, and some that have just been released actually last week and the week before. One of them coming out of the University of College of London, which we'll provide the link for, but it's the Social Biobehavioral Research Group at the University of London, and they published an amazing document that also was talking about just the summary of really looking at longitudinal data over a 5-year period in both, excuse me, UK and USA. I think some of the interesting things from those findings is that, that relates to our subject here, is that they really showed a lower risk of depression and dementia in later life and lower levels of chronic pain and frailty and even a longer life. So I don't know, I just feel like, they have some amazing large studies over there where they're looking at 320,000 participants over multiple years. And I think it's wonderful that there is all of that research being done to really say like, no, this actually can really work. And not even for, the patients or the clients, the older people, but also their caregivers. And there's been some beautiful studies with that as well, how the arts and bringing in people together to museums and other places can build up the social cohesion and really impact health and well-being for everyone.
Thank you both. It's a really great start for us today. And Sudha's point about these other countries that have national health services is really well taken. And you're beginning with this question of how does this kind of program increase access to the arts? It is really important in the US when we have the word prescribing to be careful that we say that the point is to increase access, not put arts and culture behind a kind of like wall that people have to get a doctor's approval before they're even allowed to access that, right? So a lot of people in the US can have a nightmare of a time sometimes getting their prescriptions approved, getting them filled, getting them refilled. So we want to make sure that there's not any confusion that, we would want a similar circumstance with arts and culture, but indeed the point is to increase access. And what we have seen from studies and from our work here in Massachusetts and the US as well is that quite often there are things happening in people's communities that they're not aware of. To Sudha's point, it's awareness and access. So people who didn't even know that there was an opportunity for them become aware of that through their healthcare provider or through some other kind of social care provider that opens up that opportunity for them. And then, of course, the access piece. We heard some people in our focus groups or in our results from CultureRx saying things like, they didn't even realize that some of these places in their communities were places that were for them, that they were allowed to go to. They kind of conceived of those places as being more for tourists or for somebody else. And so we did see that there were a lot of people who both found out about something that they hadn't heard of or learned that something that they had heard of was actually relevant and applicable to them and that they could access it and access it for free. And sometimes we see this much more in other countries. We're trying to develop it here, but with help for transportation and help for other forms of access to get to those opportunities, which is so important.
How does social prescribing for the arts, in your view, differentiate the really vast array of cultural experiences? And I put cultural experiences in quotes. Is a one-time experience, say a visit to a museum, as effective as a more sustained engagement that builds skills and social engagement over time? And at this point, I would add, does it matter? Are we just trying to get across the concept?
Well, it's a great question. And I would always say that it depends whether something, when you say is a short-term kind of thing, like a one-time visit someplace, as effective as a longer-term engagement, it would depend on what effective means to you, what condition you're trying to address, what the problem is or the opportunity is that you're trying to make a difference on. And there are some things that we have, what we would call dose and duration literature, like how long did somebody participate in something and where did they get effects? And so there are some kinds of activities like expressive writing, creative writing, where people participated in something for just 3 days for a really small amount of time in those 3 days and saw measurable differences in their rates of depression or mood or subjective well-being. And then, of course, there are going to be other situations where if somebody's, for example, the dance classes for folks who have Parkinson's disease, of course, you're going to see, I might not say of course, but it seems kind of intuitive that you would see greater gains and for people who are participating in those kinds of classes on a regular basis over time. And then for that other factor of social connection and social cohesion, you can meet somebody and have a sense of belonging in just one moment that can have ripple effects. But if you want to establish a kind of community and ongoing linked relationships, then it's it can be better to have a place where you can trust. I'm going to show up there maybe every week or a few times a week or whatever the case may be, and reliably have some of those relationships that you can encounter and interact with.
What we have found through our interviews is that just as the term social prescribing covers a varied lot of definitions, so does cultural experiences constitute a vast array, like you said. So our interviews suggest that on the one hand, there are arts programs that run for 6 to 8 weeks, that they're not one time, but they're also not unlimited. Some UK programs have found a way of involving people who want to continue, but others have found it a challenge to figure out what to do with people who have completed that particular program but want to stay engaged. On the other hand, there are also arts programs and participations that are designed to be one-time events. Like in Canada, there are several prominent organizations or art galleries that set aside a certain number of tickets to distribute to people who have been referred through social prescribing pathways. So this is not a sustained engagement. Now, this is not exactly our research question, so we're not investigating the benefits or the comparability of these two modes, but so we are just treating participatory and sort of receptive arts as the same. And this is definitely an area that needs to be explored. And I think, Tasha, somewhere you have mentioned that listening to music can have as good an effect as playing an instrument.
Yeah, depending on what the situation is, how you're listening to it, what your expectations around it might be. There's benefits from listening to music as well as from making it, from watching people perform it, these different kinds of things. And to Sudha's point about access, after somebody might have the initial referred experience, they might want to continue. We have seen from people in the social prescribing space a recent study that came out, I think, early last month, that was looking at people's emphasis on the idea that we don't want only healthcare providers to be able to refer, but we want people to be able to refer themselves. We want fellow community organizations to be able to refer people, so that access doesn't become limited, and so that people can continue their experiences. That's a really important point for access.
Yeah, I'll just add a teeny, part of the goal that we had in developing CultureRx social prescription was to increase health and wellness for all people of Massachusetts and to widen and deepen audience engagement in the cultural sector. I think those words widen and deepen are really important because you're right. I mean, depending on the intensity, breadth, the duration, all those things are important. But to what both of our guests here are saying, and also I just want to plug this book, which has been amazing, which we'll have a link in. What they have discussed is that whether you are the maker or the beholder, engaging in the arts can benefit you. And certainly there are studies, I think, especially around looking at frailty with older adults. And with a study that I had mentioned before, they looked at 4,000 older adults, and they did find that the greater cultural engagement you had, the lower the risk of frailty, in that one particular study. But I think overall, we just know, arts and culture, it's good for you. And it's, especially if we can address issues of isolation, it's, I think, just a way to say a big yes to life and provide those avenues for older adults to thrive in.
How are these kinds of arts and cultural experiences financed and delivered outside the US?
Financing has been one of the sort of points we have tried to uncover in our interviews. And it seems to be very varied, and not only across countries, but also within countries. All right, so on the one hand, there are varied definitions of social prescribing. And as Käthe, I think, just mentioned, that there is a move to include self-referral. All right. So the big question then arises, how are the arts programs who are receiving persons through the referral process able to offer their programming? So there is a combination of philanthropic grants, of research grants for demonstration projects. In the UK, the Arts Council funds programs in various places. link workers try to find out when they have their initial conversation with the patient, they try to find out their interests and what's available and whether that person has an ability to pay even a token amount for participation. So it's this ad hoc kind of cobbling together funding from various sources. Now, I must say this that the link workers or the connectors are key to the system in every country, but also the most vulnerable as they have been described as overworked, under resourced, underpaid. So funding for them is an important part of the system. In the UK, the NHS funds link worker positions in a range of healthcare settings, but individual physicians or the directors of those settings must apply and seek such positions. Now, has been uncovered in a couple of our interviews, so it's not like I'm an expert on the UK NHS, but this is just what we have learned. So if they apply for those positions, they can get a link worker position, and this leads to an unevenness in distribution and financial support through the UK. So the arts piece is not funded through the healthcare system. The NHS doesn't put money into arts providers. They put money into the healthcare professionals, and they put money into link workers to some extent. And then the heavy lifting is done by the arts providers in a way, and they just get a range of fundings, whether it's the UK or the USA. It's a patchwork from one province to another. This is a gap in our knowledge in terms of the link workers and the funding sources.
The US GDP, we invest 18% of our money is spent on healthcare, and that's almost double what it is in places like Canada or the UK. And when you look at the different systems, I think that as we would just mentioned, the NHS, the National Health Service, really also includes incentives to lower healthcare costs. Our whole system is a little bit different because, providers are paid per service, and therefore, this incentivizes providers to have patients use the services more. And so I think we have a little issue because sometimes by trying to have a social prescription, that also may be the result of reduced visits, because actually that's what we want, right? But this also could be reduced revenue. So we have a lot more kind of to figure out here with a much more, I think, complicated system. So that's part of the barriers that we're looking at.
Well, I would just say that it's helpful sometimes to remember that there's a big kind of like structural work to do around things, and that we do we need to figure out funding for arts and culture? Yes, as far as social prescribing, but we are not alone in this work. If you imagine anything that's a non-clinical referral that a healthcare provider might refer somebody to, whether it's housing assistance, food assistance, support groups, like all kinds of things that might be happening in your community, all of those programs are having to figure out how to finance their work, right? So this doesn't give us immediate solutions, of course, but I think that we can find some camaraderie in the collaborative nature of this. How do we figure this out? And to Käthe's point, how do we incentivize creating an environment, a community in which people can thrive versus incentivizing increased points of care and interventions for people once they have not thrived, right? How do we make a system in which the goal is to create a social ecological environment in which humans are most likely to thrive? And that's really what we have to look at. But that's not the way that our system is set up now.
What attention has been paid or would need to be paid to engendering trust in social prescribing for the arts among the public, especially communities of color who've experienced and continue to experience discrimination in healthcare?
Yeah, I think it's a great question, because I think really being as open as possible about to the historical reasons for mistrust, and of this sort of ingrained injustice that we have right now in our society, I think is important. And I think to acknowledge and work with those feelings of fear, anger, pain, all of that we've actually had to be doing as we were working on social prescription, because we needed to be able to really see how can we be very accessible. If we're going to be accessible to all, that means really understanding what has happened in the past, and having more cultural humility for some of our organizations. But the big part is like, okay, for those that you're trying to help, how can they help to design the programs that you are trying to offer? And I think that that notion of centering the wisdom of people who are typically not understood as experts, but who have the lived experience to inform the issues, the challenges, and the solutions are super important. And a good example of this is the Trust Transfer Project, which we'll give links to for people, because I think it's just so important to look at that particular model where they were trying to unify around the whole notion of building up vaccine confidence. And this was
Yes.
between Community Music School of Springfield and the Springfield Cultural Partnership. Um, and I'll just read one quote because I just think it's so beautiful. This was by Vanessa Ford, who says, "People are recognizing that it takes leaders and influencers from the community to create change. Change is truly possible for people when funding is backed with deep listening and communities that are given the tools and resources to be able to heal themselves. This change is deep, powerful, and replicable to every city."
I think this is a really important point, and some of the things we are uncovering in our interviews and our literature review include the fact that there are comparatively fewer studies published on this point about engagement and trust building with underserved, marginalized, disadvantaged communities. I mean, the terminology is a little different in different countries, but and one of the other hats that I wear is that of community engaged research. And what Käthe just said is key, that you have to work in collaboration with communities, community organizations, community members, and representatives to design and deliver and raise awareness of programs. These top down approaches do not build trust, especially in a societal climate of all these countries that have had good reasons for mistrust.
Yeah, I share Käthe's and Sudha's passion for community engaged research. I've done a lot of my work with young people involved in the juvenile justice system in the U.S. And it's just so important. Whenever I give trainings and developing programs that are connecting arts and health, I'm always saying you don't develop a program that's for or about anybody. You develop a program with them. Yeah. And, don't try and develop something without people. And I think that the opportunity here, versus trying to think about how do we get people to trust something that a healthcare provider is giving them, the opportunity here is to help healthcare providers trust the community's inherent knowledge of what they do to be well. What are the healing practices that they have had for decades, for centuries, through all kinds of ordeals and situations of oppression? How do we recognize that they know what they need to heal and then give them more access to that, as opposed to trying to think about the trust going the other way around, if that makes sense?
Going on from that one, let's look at broadly, what challenges do you see in unfolding social prescriptions for the arts for older adults into the U.S. healthcare system?
The biggest thing that we've got to really work out is, what is going to be this prescribing model? How can we really deeply integrate it within other prescribing models? So we're not just kind of like the one of or a different thing. Because one of the things that we are fearful of is just like, we don't want to just become another pilot after another pilot, and how can we truly work? I mean, Diantha, when you mentioned about the whole definition of social prescription and having its deep roots in social determinants of health, how can we really build our alliance with that whole body? Or as Tasha was just mentioning, it needs to be an advocacy of us all to say, look, these things are so important for health and well-being, and we need to have the work for all of us, so that the prescription process isn't just so cumbersome, to be able to have it really flow with funding.
And I would just say, we have some of that other collaborative work that we need to do with other partners in our systems and our communities, is that idea of even if somebody has free access to go experience art, that doesn't mean they have time to do it. It doesn't mean they have childcare. It doesn't mean that they have a meal prepared for their family after they get home from that. There's so many different things to consider in our society, anything from paid time off, universal healthcare, universal basic income, these kinds of things that would make actual access to things more possible for people. It's not always just the financial barrier, but all of the other components that can come along with that. And of course, if we had more connected communities, there's something to be said, not just for the systems and the structures that could be more helpful to their communities, but for interconnected communities that are doing mutual aid and mutual care. We can help shore up some of that to help these programs advance as well.
In the US, older adults, while we don't have universal health insurance, but older adults, like 95 to 97%, are covered by Medicare, Medicaid, VA, and so on. But still, there's a training component involved of getting practitioners aware of how this social prescribing is going to work for them, making time for that in their preventive or curative healthcare visit time, training and connecting link workers, raising the capacity of arts programs to respond to the increased need. And there probably is going to be a lot of paperwork and to be maintained. Then the UK is trying to develop training standards. So could we take and adapt these for the US? There is generally knowledge of SPA is still not high, even in the UK and Canada. It's not like completely everywhere. It's not universal. So the US is going to be a lot worse. Now, we have to raise awareness of the distinction between art therapy and this kind of arts participation.
Yes.
Which is, art therapies, that is already an established pathway in the US healthcare system. And I think definitely Canada and UK also.
Well, we are touching on such key points, and it's disheartening in one sense that they're so large and so connectedly complicated. But on the other hand, I think articulating them helps us get new perspectives on the whole. I'd like to turn.
And if I could add just like a sliver of hope, though, that what CultureRx shows us in Massachusetts is that if you are in a community, it's worth trying something. You can make you don't have to wait for your entire state or your entire country to establish a program. You can make these individual connections between a healthcare provider, between a social care provider, and an arts and culture organization. And there are resources for developing that work so that, as Sudha was saying, you as an arts and culture organization, if that's your role, are prepared for the people who may be coming through for those reasons, or that if you are, as a healthcare provider, interested in this, there are things that you can learn right now. So you can try. Don't wait for us to figure out all of these things before you are willing to try something in your community. There are paths forward if you want to explore.
The question is, what are we beginning to learn? What do we hope to learn from some of the pilots underway in the US? So maybe, Käthe, you could talk, both you and Tasha could talk to what you learned and where the hope is.
Well, I'll start with just a couple of things, but Tasha, she did an amazing evaluation, which we'll share that report, but with some real distinct findings. I think some of the things that came out that were kind of surprising. I'll just start with a couple of quotes, because part of it is, a physician that can say, it feels like prescribing beauty in your life, and part of it is like, okay, we're also working with burnout of staff, of, healthcare, of so many different people. We're all pretty tired after 3 long years of the pandemic. And, just really looking at, when there's still so many challenges, especially in mental health and providing access to mental health care, some of these pediatricians were saying like, gosh, at least I could do something. At least I could prescribe something that could feel like it can make a difference. And that's where you have a quote like, "This was the best doctor's visit I've had in 72 years. It was so fun because I get to have theater tickets." And what that feels like, especially as we emerge after so much isolation, to be able to come together and to have a reason to go out and to have that feeling of like, okay, I can go back again too, I think was just, excuse me, really important.
Yeah.
So those are just
the impact on the different participants at different levels.
And I think, for people who might be listening who are like, well, I do a really specific thing for older adults, and the organization across town, they do something incredibly different. That's really something that we tried to look at in CultureRx, not kind of trying to evaluate every single organization in the exact same ways, because they were all setting out to do different things. Their goals were different. Their interactions with participants were different. And that's one of the brilliant helps of arts and culture. And one of the difficulties as well, if you're trying to measure it, is that arts and culture does so many different things for people, but no specific organization or program does the same thing as the next one either. And they're not even trying to do the exact same thing, So there needs to be an evaluation process that can honor that and illuminate the differences. But to your point, Diantha, and to Käthe's point, as far as like what we were seeing, there are opportunities for people if they feel disconnected or isolated, to be able to encounter other people and reconnect. But also in arts and culture, there are opportunities for people who maybe they don't want to go out in a crowd of people. They don't want to like make friends, but they want to maybe leave the house, or they want to have a reason to be out and about, or they want to go explore their own interests, or just spend time in an interesting or beautiful space. And there are opportunities for that too. So it's not, there doesn't have to be, if you're going to be engaged in arts and culture, you're going to get some kind of, it's going to be some standard cookie cutter experience. There are ways to adapt this. And to Sudha's point, I don't know if we've defined link workers yet in this conversation, but these are people who get a referral from the healthcare provider, and then they take their expertise as far as what exists in the community, what might benefit people, and help each patient try to figure out where they want to go, how they're going to get there, et cetera. That's part of that. The value of having that expertise in our U.S. programs, which we haven't quite seen consistently here, is that there is that opportunity to customize an experience for people and to help them come across something that they're really going to enjoy. Or if they try something and they hated it, that's not the end of the road. There might be another option they can pick up and try again.
Yeah.
And I do have to say, I mean, just to your point too, Tasha, that, that's, I think, one of the incredible challenges that we felt, especially as we did phase after phase of this in a pandemic, is just, the trying to rely so much on the pediatricians' offices or other healthcare areas without having that distinct link worker is really difficult, because especially as health issues became so, I mean, when we were having the triple pandemic, for instance, in the fall, it's too much to try to rely on it. So that, therefore, in our next iteration, where we're actually going to be finding another entity to house this, to take it on. But the link workers are going to be very, very key, because we have found that is crucial. And that can't just kind of be assumed that even if a very passionate pediatrician's office, is there, but man, stuff happens, and we really need that role of the link worker is so important to be able to make those connections and build the trust, et cetera. So we will be definitely looking at that.
Yeah. Sudha, could you add to this by making some observations on any programs that you see existing or coming about in the U.S. that are comparable, that shed light on how this could work in the U.S.?
We haven't completed, or we haven't begun our US interviews yet, so I'm not sure that I can give you in terms of here's a program and they have been evaluated. But I know that there are options popping up, coming up as pilots. There is something that involves pharmacists also.
Yeah.
There is, from the arts program side, there's a Creative Aging Network, which is a national organization, and it also has state chapters. So there's a variety of things. And the US is so vast, and every state has its own kind of terrain. And I just once again like to reiterate that the link workers are the term used in the social prescribing field, but the US healthcare system has patient navigators, it has family life specialists, there are social workers embedded in different parts of the healthcare system. So there are people who have some of this expertise already, and some additional strengthening of those staff and training for this role would also, I think, be another entry point into the system.
Yeah. I know in Cleveland, they now have tried to have someone based in the Cleveland Clinic.
Yeah.
New Jersey, there's a person starting a program with funding from an insurance company based at the New Jersey Performing Arts. So I think we're going to see different models and probably different terms for these connector people. And I think what's exciting to me is that we are sort of at the beginning of a national conversation about social prescribing for the arts and its potential benefit for the well-being of older adults. And I think this session and parts of this session may be very, very helpful to other people who are starting to engage with these same issues. I just honor you for all the work you're doing and the creative thinking around it, and being able to see it in a larger perspective, which can be daunting. So thank you very, very much for your contributions. And we will we hope that many people can benefit, as I have, from speaking with you. Thank you.
To receive more information about this topic and other topics related to the creative aging field, please visit the Creative Aging Resource website at creativeagingresource.org and sign up for our online journal at creativeagingnews.substack.com. If you're interested in learning more about arts education programming for older adults and implementing this programming in your organization or community, please register for our free self-paced online course, Creative Aging Foundations on Demand, by visiting beagefriendly.org. To learn more about our ongoing work and impact in this field, visit the Lifetime Arts website at lifetimearts.org.